Next session will be an interesting debate on multivessel PCI.
Now we have Hemanth Kaukuntla. He will talk on the defense's results. Surgery is superior to PCI.
Good evening to everyone and all. A special thanks to the organizers and in particular Dr. A. Srinivas Kumar for inviting me for this, which I think is a difficult topic. Particularly, I am the sole warrior here. As is customary, my first few slides, the first 3 slides, will have to be controversial. That's the whole purpose of the debate. But I reserve my own thoughts to the last 2 slides. So, the biggest threat today to patient care is the inappropriate use of PCI for patients with multivessel coronary artery disease who should have been offered CABG. It takes great courage for me to stand here and talk about CABG being the sole modality of treatment which should be offered to patients, saying this statement. But the real world situation is completely non-evidence based, and that is a problem, as I come to in a minute. Not offering the most effective treatment for prognostic benefit, that is, not offering CABG today is not only wrong, I think is criminal. What is undebatable is that patients, me inclusive, patients, hospitals, healthcare, countries, everybody wants less invasive solutions to their medical problems. And I think that is right. But what is the problem? The problem is informing the patients that PCI is less invasive and stopping there. The problem is not informing the same patient that PCI is not as effective as CABG, not informing him or her that it impairs survival when compared to CABG, and of course, it is more expensive. So my argument today, Mr. Chairman, is to show you in the next 13 minutes that CABG is better for multivessel coronary artery disease symptomatically, better prognostically, and also financially. And as I mentioned, give my own thoughts in the last 2 slides. The evidence was always there. We were just not ready to accept it and take it. That is the bottom line. This is the classic trial from Yusuf et al., published in 1994 Lancet, which showed CABG versus medical therapy. Now, I'm not even talking about PCI, but the evidence always existed that CABG is better. It was 2,650 patients followed for 10 years. Now, they said it is particularly beneficial for patients with severe symptoms, triple vessel disease, or impaired left ventricular function. But what I am emphasizing is that they showed that with CABG, there was no survival benefit for patients with single vessel disease, double vessel disease, or patients with normal LV function. And I will allude to this because this, I think, forms the basis for my next 10 slides. The criticism, of course, this is medical therapy, not PCI. I fully agree. They clearly showed that there was no survival advantage in a certain group of patients with CABG. That is the take-home message from this first trial. Of course, the science has moved on. Aspirin, statins, we all agree statins have made a big difference to the outcomes, both in medical therapies, stents, or in surgeries. There have been advances, as we have seen, bare metal stents, drug-eluting stents, and advances in our specialty as well, left internal mammary artery. I think that is the crux. Arterial revascularization, off-pump surgery, and minimal access surgery. I think these have made a big difference. So, newer data has come. This was 15 randomized trials wherein patients with triple vessel disease were followed up. And there is again no question, the reintervention rate in the PCI group is higher. Mercado et al., JTCVS 2005, they said the stents when used, the first 1-year survival was similar. These are the summaries. Now, very briefly, all I want you to concentrate on few facts about these trials. This slide is about the one without stents, and my next slide is about the one with stents. What is clear in these is the percentage of true triple vessel disease in this study. Maximum was the Iraqi one with 45%, and all the studies had good LV function. And the percentage of population which were randomized is very small. When coming to the stents, again, percentage randomized small. 3 vessel disease, maximum 56%. Ejection fraction, everybody had good LV function. So, my conclusion from these studies is that 60% had single or double vessel disease, all had normal LV function, and only 4% of the screened population were entered into the trial. So what is it going to say? It is going to say what was told 20 years ago. That is, CABG is not going to show you survival benefit. So of course, PCI will be similar to CABG in terms of survival. So, in my view, the conclusion of these studies was there even before the studies began. But having said that, somewhere in the history or in the literature, it is lost. Hoffman et al. With 13 of these trials showed that small but statistically significant survival benefit in the same trial patients. So, what has this led to? This has led to inappropriate use to justify PCI in all patients with triple vessel disease. Of course, CABG was never going to be better than PCI in this group of patients, as I have shown you earlier. 2 trials which have been quoted a lot are the ARTS trial and the SOS trial. 1200 patients, no difference in 1 and 5 year survival, and reduction in the reintervention rate by CABG by a factor of 3. But again, 70% single or double vessel disease, all had normal LV function. But even in this trial, in the diabetic subgroup, they showed that CABG is better than PCI. So, the truth has started to come out slowly. In the SOS trial, again the same things. Reintervention rates were higher for PCI, mortality was low for CABG. So where is the real world? The real world registry, this probably is one of the best papers. 60,000 patients from the New York registry were propensity matched, and at 3 years, clearly there was a survival benefit for CABG patients in multivessel coronary artery disease. And as expected, repeated revascularization was 7 times higher. But cardiologists will have to say, but we did not compare our drug-eluting stents. Absolutely true. This data is pre-drug-eluting stent era. But having said that, I will ask a basic question. Are drug-eluting stents really the answer? Are they better or are they any good? Well, the true rates of restenosis are 10 to 30% depending upon which article you read, and 2 meta-analyses have shown that in which involved 5,000 patients and whom results were looked at 6 to 12 months with intermediate and medium lesions only, long lesions excluded mind you, and the restenosis rate were lower, but they did not show any change in mortality, meaning there was no survival benefit. And late thrombosis and increased mortality, I do not have to talk about to this esteemed audience. So, newer data has come, the Syntax trial, 1,800 patients, triple vessel disease, or in drug left main stem, which will again be alluded to tomorrow, drug-eluting stents versus CABG. Now, death, stroke, MI, and repeat revascularizations were compared, and again, CABG was better. These results are at 1 year, and the conclusion in that paper was this is early results, and if you remove the revascularization rates, there was no difference between the PCI and CABG. The truth was hidden again. So, the 3-year follow-up data. Now here, it's quite clear. The rate of MI was more in the PCI group. There was no difference in the stroke rate, something which was alluded to in the Syntax, the 1-year follow-up. The cardiac death was more common in the PCI group, and the difference is quite clear in the higher risk groups. But again, if you read this paper, the conclusion is more about the low risk Syntax data, not to emphasizing that PCI doesn't work in triple vessel disease. Now, more newer data, the ASSERT trial, which was presented in the March 27th meeting at the ACC, health outcomes of 190,000 patients. Patients who underwent PCI had a higher death rate in the first 4 years, and CABG was better in the high-risk patients. Diabetic ejection fraction of less than 50, more than 75 years, or GFR, which is less than 60. And April 16th, in the diabetes research clinical practice, the diabetic patients, 9 randomized controlled trials, all clearly showing that the repeat revascularization is more, but more importantly, the 5-year mortality is significantly higher in the PCI group, the risk difference of 7%, and the major cardiac and cardiovascular risk difference of 12%. So let's keep the evidence aside and let's look at the financial argument. Now, I had the great honor and privilege of working with Professor Taggart, and then this is something which he had made a comment about. In the absence of substantial clinical evidence of superiority of stenting with drug-eluting stents over CABG, to encourage the widespread use of drug-eluting stents will drive up the cost of stenting, and if allowed to displace CABG, reduce the gain in quality and possibly the duration of life arising from CABG in the long term. Now, this is the NICE guidelines, the National Institute of Clinical Excellence 2004, which is a guiding factor of how health budgets are commissioned in the UK. So this is important. Let's look at the Indian scenario. I appreciate that we do not have much data, but there are some clinical findings which are quite important. We have more diabetic patients. Coronary vessels tend to be smaller than our Western counterparts. Now, CABG offers more complete revascularization with more durable grafts, particularly the internal mammary artery in patients with small vessels. There's another thing, while looking at this, we looked at our own state data. For those of you who do not know, we have an Arogyashri program in Andhra Pradesh, wherein people are offered free treatment, particularly with regards to our specialty, CABGs, and also bare metal stents. Now, these are the cost implications in rupees. As you can see, the whole state is divided into 5 phases. That is, each phase has some districts in it, and CABGs, and so this has started in 2004. I am showing you the 2008-2009 data. Now, all I want you to concentrate is the totals in all the phases. That is, throughout the 24-25 districts, we have a total of 5,000 CABGs were performed, 12,250 first stent. So the way the calculation goes is you have, as I can show you, first stent is one code, second stent is another code, the third stent is another code. So first stent, about 12,000. If a patient had a second stent as well, another 5,000 patients fell into that category. But if you come to a third stent, I'm not even saying here that these are triple vessel disease. I'm just telling that a third stent was used to a patient, 100 patients. There has to be some sense in Arogyashri people also saying, guys, you can't use 3 stents. So why will PCI never match CABG? That is because CABG deals not only with the immediate culprit lesions, but also deals with the future culprit lesions because the graft is in the mid or the distal vessel. And I think this is the crux. So the guidelines have come. There is class 1 evidence that revascularization improves survival in triple vessel disease, or it improves the survival with LV dysfunction patients, or it improves the survival in patients with complex coronary artery disease and also with diabetes. But having said that, they also say that PCI, the usefulness of PCI to improve survival is uncertain in patients with 2 or 3 vessel disease with or without involvement of the proximal LAD artery. Then the level of evidence is B. So the guidelines are there. But guidelines are guidelines. Symptoms, it's reasonable to choose CABG over PCI again for symptomatic purposes. So what more evidence is needed? So why am I discussing here when there is so much of evidence to say that CABG is better? I think this is again David Taggart's comments. Cardiologists probably are the gatekeepers. They are the gatekeepers, and they may put conflict of interest, inappropriate application of RCTs, and probably we are fighting a multi-billion-dollar industry. So my own thoughts with the last 30 seconds, Mr. Chairman. This, I think, is my own thought. This is Dr. David Hills, a cardiologist, who has said the heart team approach. Now, I think a lot of thinking has to happen, in terms of allowing the heart team, that is a cardiologist and a cardiac surgeon, to get involved in the decision process. But my own thought is, like CABG, PCI has a definite role and will continue to save millions. But for the triple vessel disease, CABG is better. Thank you very much, Mr. Chairman.
I must compliment Dr. Hemanth for the eloquence. In the Abhimanyu-like fashion, he has come amongst cardiologists to state his point of view.